The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Thanks everyone for coming. Welcome to Friday Morning Medical Conference, sponsored by Western Montana AHEC. My name is Dan McCarthy. I'm a family medicine residency faculty over at Partnership Health Center. We are very pleased to have Dr. Mariah Bonner here to present on social determinants of health. Dr. Mariah Bonner is a third-year resident from the Family Medicine Residency of Western Montana. She comes from Seattle and San Diego. She did her undergrad at San Francisco State University. And she completed osteopathic medical school at Western University of Health Sciences in Lebanon, Oregon. She has a strong interest in social medicine with an emphasis on public health and social determinants of health. Mariah plans to stay in Western Montana and practice full-spectrum family medicine with obstetrics and osteopathic manipulation. I'm also pleased to present Dr. Elizabeth Paddock, who is also faculty at the Family Medicine Residency of Western Montana. She went to undergrad at Cornell University and medical school at Albany Medical College and residency at the University of Wisconsin-Madison. Thanks again for coming. One request, please save all your questions till the end and use the handheld microphone to ask all questions. Thank you.
Thanks, Dan. This is working? All right. So first of all, this topic is very broad. It's huge. So Dr. Paddock and myself are hoping to do a broad overview, kind of breeze through some of the main topics and talk a little bit more about how we can utilize that in the clinic setting. All right, so some of our objectives, basically to define some of the health inequity and inequities in our society, learn a little bit more about how to utilize that information, and then how to incorporate that into a clinic setting wherever you may practice. So as we go through this talk, I just want you to think about patients that you may have encountered that where you're not really able to help them just in that clinic setting. They have some kind of barriers to their health that you're not really able to help them with. They're not able to get their medications. They have a unstable housing situation where they're not able to use their medications. Just most recently, when I was on inpatient medicine, we had at least a handful, maybe 5 or more, of just homeless, alone patients. That alone, if you're homeless, if you don't have stable housing, how are you supposed to get your medications, use your oxygen, use your CPAP? They're very limited by their resources. So we'll talk some about healthcare money, how it's used, outcome discrepancy, the term weathering, and race, ethnicity disparities, genetics versus epigenetics, how where you live defines your health outcome, a little bit about cultural health, and then what we're doing in partnership to work with some of this. All right, so some of the definitions, 2 main websites, the CDC and the World Health Organization. So the CDC, as defined right here, is the conditions in the environment which people live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes. I kind of like that one best. It's short, it's concise, gets to the point. The World Health Organization says that it's conditions which people are born, grow, work, live, and age in a wider set of forces and systems, shaping the conditions of daily life. So these forces and systems include economic policies and systems, development agendas, social norms, and social policies and political systems. So it defines it a little bit more in the construct of our legislation. All right, just a recent article, the Public Health Reports, they concluded that half or more of all deaths in the U.S. involve behavioral causes. Doesn't seem too surprising when you think about the patients that we're helping. And other evidence has shown that health-related behaviors are strongly associated and shaped by social factors, including income, education, and employment. This is a small graph that I got from this article that just demonstrates we know that education makes a difference in our health outcome. So the y-axis shows life expectancy, and then if you look at the colors of each bar, farther to the left is less than high school, while farther to the right is college education. All right, another visual to look at how the social determinants of health and social factors really determine how our health outcomes play out. So further to the Further to the right, you'll see the downstream effects. And you also see that that's our current public health practice. So we're practicing to combat disease and pathology when it shows up. And if you look further to the left, the upstream factors, these are also where we're trying to work with our social factors and public health initiatives. So you can see that up farther to the left, there's culture, there's race, sexual orientation, gender. In the middle is some things that maybe we could do on a local level to help out with housing, food availability, employment, environment. And of course, the nice orange color on the slide, which designates how we can make some changes in our policy. All right, all of this is really to demonstrate the metaphor of the upstream intervention. So if you make a intervention further upstream, you're going to have larger effects downstream. And this is another way that we just want to emphasize that upstream, there's a lot of things that we have a hard time doing much about it. Culturally, we can have a huge culture shift. I mean, we've seen a ton of culture shifts just in our society recently. So they can change very drastically, but it takes a lot. While the middle stream is kind of where we're focusing, especially at Partnership, to really make changes, reaching out to people, getting them connected to the resources that they need, including housing, environment, relationship safety. And then, of course, down at the downstream effects. So this is where we're treating patients, medications, procedures, surgeries, all those things. All right. Another way to also look at our social factors. So this one does not come in a stream metaphor, so to speak, but it's more of a circular demographic of how to really look at how these social factors play into our health outcomes. All right, so the easiest way, if you could take away one thing from this, is the social determinants of health are really where we live, learn, work, and play. And then going a little bit deeper, it's also determined by our race, our culture, sexual orientation, gender, disability. And we know that individuals face stigma, discriminatory practices, and social exclusion in many facets of our culture life. So briefly on sex and gender norms, we understand that we're born a biological sex, and culture defines how that plays out. It determines how we interact with one another. In general, social norms, culture norms are not a problem. They form how we view the world and ourselves. They help us predict our behavior. But sometimes when this is amplified, when people don't conform, that can cause some discrimination and psychosocial stress. It can limit access to resources. Overall, social determinants and social factors of health, it's a complicated problem with complex solutions. We need a multifaceted approach and a multidisciplinary team, as you might imagine. There's a recent poll you may have heard of, the Robert Wood Johnson Foundation that did a huge poll in 2017. I wanted to highlight this study that they did because it illuminated the discrimination among different ethnicities. Especially they polled Native Americans. Historically, Native Americans have not been included in polling in the United States. And just by not even being included in the conversation, they're just left off the table. But this is very interesting because it showed that the social psychologists, we know that social psychologists and scientists have recognized that prolonged stress in the form of discrimination has detrimental effects. So in this poll, they found that 1 in 4 reported discrimination when going to a healthcare provider. And you think about that when you see your patients. None of us want to discriminate our patients, but we think, well, what am I doing that is making them feel not welcome? So adding on to that, the weathering hypothesis. So this is, it's a hypothesis where living in a society with a strong history or legacy of discrimination could damage health through psychological and biological pathways. So even without overt discrimination, people still feel discriminated against. This may explain that discrimination is really more of an experience than the socioeconomic status that we used to think it was that really determined health inequities. The idea is that this psychosocial stress is a cumulative experience that prematurely ages an individual or weathers them, so making them seem older than they actually are. We know that when controlling for education, for financial status, and other social factors, there's still racial disparities. So this highlights how important this weathering hypothesis is. And lastly, it kind of comes down to, well, is this genetic? Some people will say, oh, well, it's there in their genetic code. I would argue that maybe it's epigenetics. So a case study recently that we came across in our research is a 36-year-old new African-American mother. She was an epidemiologist at the CDC. She had a BA in sociology, 2 master's degrees, dual subject PhD. She had great insurance, great social support. 3 weeks after giving birth, she collapsed and died from complications of high blood pressure. So there's a lot of things you could speculate about what happened during her care. But in the end, we know that African Americans have a disproportionately higher rate of maternal mortality than the rest of the United States. Alone, when you look at Black college-educated mothers who gave birth, were more likely to suffer severe complications of pregnancy or childbirth than white women who never graduated high school. Again, the highlight of the feeling of being devalued and disrespected by medical providers. And whether that is truly happening or it's just their experience, it's hard to say. So briefly on the topic of genetics versus epigenetics, we know that genetics is our DNA, it's our genetic code. We pass it on, it determines our phenotype. So epigenetics, it's a study of changes in the organism by modification of gene expression rather than alteration in the code itself. So a highlight of this, or an example of this, would be identical twins. We know that they're genetically the same, but we all know identical twins. They're not exactly the same. They're all quite different. They look different, they act different, behave different. So the epigenome is dynamically responds with the environment, especially to stress, diet, toxins, and other factors. I like to think of this as taking a highlighter to the genetic code. So you can highlight certain parts that you want to emphasize, determined by what kind of environment you see, or you can cross other things out that you don't need. What I found really fascinating is that epigenetics can be inherited. So things that we actually see as racially genetic, are they genetic? Or is it just epigenetics being passed on? So when I think about African Americans and how we treat hypertension different with calcium channel blockers, is that genetic or is it epigenetics? Is it the psychosocial stress that has occurred for centuries in this country? And we see it in other studies, so addictive behavior. So we know that patients that have an addiction, they can possibly pass it on to their children. We know that through ACEs. We know that children with child abuse have an alteration in their healthcare outcome later on in life. We see it with studies in famine and starvation. There was even a study with paternal famine. So there's a study in Sweden where they looked at grandfathers. When they went through a famine, their grandchildren had a longer lifespan. It's crazy to think about that those, just through several generations, that they're able to pass on genes that determine their outcome. All right, another example would be the rats, the lick your rats, which I really like that phrase because the idea is that, there's different kind of nurturing types. So the rats that lick and groom, they tend to produce a rat that is more calm. While mothers that don't do those things, then they produce an anxious rat, which kind of makes sense. You can translate to that to humans perhaps. And a common misconception in our human interaction is that an anxious or or anxiety is a disadvantage in our society. It's because we live in a nutrient-rich society. But another environment where the nutrient is poor, the low nurtured rat keeps a low profile, responds to stressors appropriately. And in this environment, the calm rat is too relaxed and eaten by a predator. I was very interested in epigenetics when I was researching for this topic. So if you want more, there's a great website by the University of Utah. They have very easy to read links and a lot of good information. So this picture just shows that these two rats are genetically the same. The mother on the left of that rat, she got a normal mouse diet. The brown rat, was supplemented with folic acid, B12, and other vitamins. So that alone just shows how the nutrient effects inside the mother makes a difference. All right, kind of changing gears, but we're switching over to how your environment really determines your health outcome. So there's a poll done in 2015 by Gallup, which does a ton of polls across the United States, looking at a patient's well-being, or not even a patient, just a population's well-being, what they perceived as was valuable to them. So they asked them about their purpose, their social interactions, their financial stability, their community engagement, and their physical health. And when you look at this, the states that feel like they are the most well, we get a nice highlight because we are in the top. But it's the western states. So Montana, Wyoming, Arizona, Utah, California. We got Alaska, Hawaii. Well, the ones that are not feeling so well are in the South and Midwest. So when you look at other factors that they looked at, it was also associated with, so the highest quintile associated with low BMI, physical activity. And the lowest quintile would be the opposite, so elevated BMI, lower activity. So we know that where you live is a factor for how your health comes out. These quintiles were associated with likelihood of faring well after an MI, associated with lower or higher BMIs, like I said. And this also makes sense when it comes to our local factors. So we know that living near a supermarket is better for our health. So it's linked with less obesity, while living near a convenience store is linked with elevated obesity and smoking. We know that people are more likely to be physically active if they have parks, bike lanes. They're able to walk or jog. There's less litter or vandalism. And I will say that Dr. Paddock will talk a little bit more about this later when it comes to Montana specifically. All right, another brief survey which has to do with the happiness of Americans. This looked at urban or metropolitan areas across the United States, and pretty much it highlights along the same lines as the states before. A little bit different, but Colorado gets a shout out with some Boulder and Fort Collins, and then California as well. So we know that where you live matters. And to transition that over to reservation and Native American health. We have reservations all over in Montana. We know that where you live matters. Life expectancy for Native Americans in Montana is 20 years shorter than the national average. 20! It's a lot. And again, we know that 1/4 of Native Americans feel discrimination when going to the doctor. Interestingly, Congress decides the budget for IHS, which works out to about $1,300 per person. And that's compared to the US prison system, which gets $7,000. So we know that there's large barriers to health on the reservation, whether that's geographic, transportation, monetary, could be culture, communication. So that brings me to cultural health. So we know that culture defines how we view the world, how we view ourselves, and it can determine how we communicate with one another. So just looking at Native American health and culture compared to ours. So we know that in an individualistic society, it's defined by ourself. The individual is above all others. We're very autonomous. We're self-sufficient. We're independent. All sounds like good qualities of Americans. They're associated with men and people in urban settings. While a collective society identifies based on the group. So depending on where you are or who you're with, that defines who you are. The team or the family is valued over the individual. And they're very close to group members, but maybe distant towards others that are not in the group. And that's also associated with women and people in rural settings. And so examples of individualistic and collective societies, individualistic, the US, as I've already alluded to, Australia, UK, Netherlands, Germany, we could go on. And then most of the world is actually in the collective societies category. So Japan, most of Asia, China, Sweden, Argentina, Brazil, Mexico. So I pose this question, is our neighbor's health our responsibility? I would guess that most people fall somewhere in the middle. Yes, it is to some extent, but there is some individual responsibility. I would argue a little bit that our individualistic society, we could stand to be a little bit more collective, perhaps. And it comes to thinking about, the trees through the forest metaphor. So this is a beautiful forest in Montana. You can see each individual tree. Our current healthcare system does very good at taking care of each individual tree. We are innovative. We come with the most up-to-date medical care, research. But I think we tend to miss a little bit of the forest and the whole ecosystem. There's a lot going on in our system. And I think there's something to be had about treating the whole community. Another way to look at the healthcare discrepancies in our society. So you see that in the United States, we spend 88% of our medical services on our healthcare, when really what determines our health over on the left is healthy behaviors. So maybe we should be spending a little bit more money on our healthy behaviors. Lastly, before I switch it over to Dr. Paddock, this actually just came to my attention in the last month. It's the New England Journal of Medicine Catalyst, which I had actually never heard of, but it's a journal for pretty much administrators and healthcare leaders. So this was published in December 2017, and they had an article essentially about this topic. They spoke of being essentially at a paradigm shift. They think that our healthcare system can no longer sustain how much we're spending on these medical services. They were quoted as saying over half of frequently hospitalized patients lack access to healthy food or at risk for not having enough. They also were quoted as saying, since social needs are a major determinant of health, our healthcare system must assume responsibility for addressing patients' unmet social needs. Lastly, they also highlighted some ways that we can perhaps intervene. So we needed 5 key drivers they talked about, and you'll probably see a lot of different information about, well, how do you combat this? I thought this was a nice example of how to go about doing it. So you need a systematic resource screening tool. So a way to find out what your patients need. What kind of unmet social needs do they have? You need a way to resource for referral and navigation. So community health workers, social workers, patient navigators, people that can connect to patients to the right resources. A dedicated workforce, so people that are excited and engaged to do this kind of work. Data systems and performance improvement. So you have to know, like, well, what have we started? What can we improve on? What do we need to do better? And then lastly, leadership and stakeholder engagement. So you need everyone in the group to be engaged on what we're doing. All right. I'm going to pass it on to Dr. Paddock for more information about what partnership is working on. Yeah.
you, Mariah. So hopefully I can build on a lot of the stuff that Mariah has started talking a little bit about. So there's kind of an argument coming from the Robert Wood Johnson Foundation talking about that it's time for America to lead on health again and trying to change the way that we talk about the social determinants of health. This will be a busy slide, but the key points really are that, as Mariah mentioned, we really do lead the world in medical care and research, but we're really failing in how long we live, a number of other things. We're failing for a lot of our patients. So we have this kind of big dichotomy of a lot of people doing really well. We have wonderful innovations, but a lot of people who aren't able to access or afford, or all those things aren't doing anything for them because we're not meeting their other needs. So they make that there are 3 key points. The first is we need to ensure that everyone can see a doctor when they're sick. The second is to build on preventative care like screening for cancer and heart disease into everything that we do, and even trying to do that maybe outside of the healthcare clinic, that this can happen in malls or work settings, places where people are. The third is to stop thinking of health as something we get at the doctor's office, but something that starts in our homes, with our families, in schools and workplaces. That same idea. Health that happens where we work, live, and play, not just in the doctor's office. The more that we're able to see the problem in this way, it also gives us a lot of opportunities to improve health. So there's a lot to go from there. This is the direction that healthcare, I think Dr. Bonner and I would argue, we should be moving in. The idea of healthcare equity, not just equality, right? Equality doesn't equal equity. If we want better outcomes, we really need to work towards equity. So we want to get everyone healthy. And that may mean that we need to give some folks a little bit more than we give other folks. So those people who start with more don't need as much. And that's the idea of that collective society versus just an individual society, I think. Again, on this side, kind of this argument that health equity is equal opportunity to housing and healthy food and education, healthcare, legal counsel, and the opportunity to be able to stay in shape and have a supportive environment with friends and family. Some of this is, I think the argument here is that, again, this is bigger than the current healthcare system, and a lot of those upstream effects need to be addressed, those things that Dr. Bonner was talking about. This is sort of interesting. I got this email from the Providence National Leadership maybe a couple weeks ago, and interestingly, right around when Dr. Bonner found this New England Journal Catalyst. This is what's happening at the big organization. So these Providence St. Joe sent out an email with the list of the things they're predicting that'll be a particular focus in 2018. There were 9 things listed, and social determinants of health was number 5. So this is big. It's of growing interest. National organizations are starting to step up. And I think ultimately it comes down to money, right? They're seeing that the social determinants of health, unmet basic needs, are driving a lot of unnecessary healthcare costs. But so they're arguing that we need to start thinking more about population health, health equity. We need to see more partnerships with our public health and community healthcare workers. We probably need to see more case management, healthcare navigators, incorporation of public health nursing, things like that. And that we're going to need more data to support the needs and also to back up the argument for these services. I will comment, though Providence is saying this, as you know, currently Montana's budget crisis has resulted in us cutting case managers for mental health and funding for organizations that are supporting individuals with disabilities. Like, we can't do that without those services. I think many of us at Partnership and clinics elsewhere are going to really see the downstream negative effects of losing those services for those folks. So though larger organizations are starting to talk about this, I don't think until we get more government support and federal funding to support these things are we going to be super successful. I think it's coming, and part of the argument is going to be that data and data-driven evidence that shows that addressing these issues makes a big improvement. I'll talk more about this down the road, but we actually don't have that much evidence yet. This is just sort of showing, similar to those slides that Mariah or Dr. Bonner was showing earlier. This is more of this Montana-specific data. So on the left, you can see the health factors are ranked by county. This includes a person's health behaviors, access to care, social and economic factors. And lighter means that you have better access, and darker are less access. Not surprisingly, on the right, this translates to health outcomes by county. So darker counties have more morbidity, mortality, and you can see those match pretty closely. Where there are better access to resources, including jobs, education, and housing, there are better outcomes. So we know that there's hard and fast data. How to fix those underlying resource issues is a whole nother story. Okay, so how do we start to think about improving health equity? The first is really to decrease disparities. So that idea of going back to that picture of the littlest kid on 2 blocks, right? We need to sometimes give people a little bit more health. So we need to start looking for disparities. We need to track outcomes that matter to patients. We need to talk to patients and find out what their individual needs are. We need to sort out the payment system. How do we pay the healthcare system, the community as a whole, to address these things? Because many of us mean well, but we can't do it by ourselves. And we really need to work on payment models. And we need to, get leadership in teams on board. So healthcare leadership really needs to buy in, and we need that at all levels. We need it at clinic levels, we need it at county organization levels, we need it at the state, and we need it at the federal level. So we really, I think, this is not to minimize what healthcare providers do. They work really hard. We do a really excellent job of addressing physical healthcare needs. But again, a lot of times the problem is bigger than us. We can't fix those underlying issues by ourselves. And a person's health is not tied only to their medical care. And this is why we need teams. We need people who are able to work with us and help us address those issues at the same time we're addressing their health. This is reinforcing the smallish part that medical care plays in achieving health. So, right, we get one line here in terms of creating happy, healthy people. Unless basic needs are met, medical care is not going to make much of a difference for many folks. We need to make sure people have food, housing, safety, and income. If those issues aren't addressed, we're putting a Band-Aid on, a gushing wound. Like, we're not going to fix it in our clinic setting. So, okay. So why should we do this? Is this just more work for me? And the answer really should be no. I think if we can start addressing these issues, we're actually probably going to address some underlying burnout as well. You're not going to feel like I can't do anything for these people, or I make these suggestions and they don't do anything, and we have the same conversation every time that they come in, or I have no idea what they're doing with their medications, so I can't adjust anything because they lost them last week, and then this week they're not sure, and I take that blue pill. But so it's really hard to take care of people who are that disorganized, but if their life is such chaos outside, they can't, this is a low priority for them. It also gives us a lot more tools for addressing challenging patients, right? So, okay, you know what, we're not going to talk about your diabetes today. We're going to talk about your housing situation, and I'm going to try and get you to some resources and folks who can help address that. I think the other thing is we really need to identify those patients who are the highest needs and make sure that we're referring them to the appropriate places. And to do that, we need to collect data. So we will get into that a little bit. This is just to touch a little bit more on that idea of physician and healthcare provider burnout. This is taken from a 2011 Robert Wood Johnson Foundation study on physicians' daily life. It's a study of primary care providers and pediatricians. And essentially, this section is saying, according to the majority of physicians, it is undeniably important to address unmet social needs. They're present across all types of communities, and not addressed will continue to deteriorate the health of America. And again, I think we're really at a point where many administration and healthcare organizations are seeing we really do need to start addressing these things. Problems created by unmet social needs are problems for everyone. Addressing patients' social needs is as important as addressing their medical condition, and unmet social needs are directly leading to worse health for Americans. And you can see that here. So 87%, 85 to 87% of sort of primary care providers agree with those statements. And then this next slide is similar. Basically, that healthcare providers find social determinants of health frustrating. A general lack of access to and knowledge of resources that address patients' unmet social needs is negatively impacting the health of patients and the quality of care that we can provide. So in addition, so 54% disagree that their patients have the resources that they need to stay healthy. More than half do not feel that they know enough about resources to help their patients. And 87% feel the quality of the care they provide would improve if unmet social needs were addressed. And I suspect, this survey is from 7 years ago. I actually suspect that these numbers would be higher as this has been kind of more in the news recently and we've been talking more about it. Some additional data from this study showed that primary care physicians spend an average of 7 minutes per encounter on the social determinants of health. But they also feel like they can't address it. So I think this leads to frustration, to burnout, to just feeling like we aren't able to provide the best care that we can for our patients. As I mentioned earlier, there's pretty limited data showing that interventions improve health outcomes, but I think that really speaks to that these are really messy. It's hard to study these, and we also, what does addressing social determinants of health mean? I referred you to social work, but it takes months. If housing's an issue, okay, maybe you get on the housing list, but that's months, years in Missoula if you're on that housing authority list. So that said, this is a really tiny study, but it did show that simply by asking patients about unmet basic needs and making a referral to social work, and that's all the study looked at, it didn't go beyond that, that there actually is a small improvement in, this little graph is from on LDL numbers, but we also saw it with blood pressure. So more to come on this. I think there's going to be a lot more data coming out in the near future because this is such a hot topic. But right now, if you do a PubMed search looking for kind of health outcomes after addressing social determinants of health, there's almost nothing. I think most of the stuff is really on, it's more on sort of looking at that these are issues, starting to collect the data on who and what are, who is needing services, what the services are, the disparities, things like that. And I think interventions are to come. We're probably seeing more data, and I'm guessing in the public health and social work literature. But so this just says, addressing unmet basic needs creates a new response for challenging patients. They're challenging because we've been offering an unhelpful answer, right? So now we can try and offer a much more helpful answer and address the underlying issues. So how do we pay for all of this, right? There is kind of a big movement towards value-based care. I think this will help. I have to say, I don't understand payment systems very well. I'm sure some of you out there have a better sense of how all of this works, but we are moving more towards the idea of looking at data and outcomes and paying for that. I'm hopeful that as part of that, structural changes will help clinics pay more for social workers, care managers, community health navigators, things like that, that are what are really going to make the difference for our patients. Patient-centered medical home is already pushing for newer payment models to address value-based care. There's lots of changes coming. And again, hopefully that's going to help pay for these services. So this is just a little bit more on that, but that 30% of Medicare patients are tied to quality or value, and we're expecting that to increase and moving towards the value-based. And it's looking at cost, quality, and access. So, and then there's a number of pilot studies out there that are investigating this. So this is a place to start. Basically, 5 strategies to start incorporating the social determinants of health into your practices. So you need teams. again, this is not the day of just a physician kind of running the show and doing their thing. This is bigger. We need a lot of help. Often start with social work, but medical legal partnerships are part of this, super utilizer programs, refugee coordinators, nurse-family partnerships, WIC programs, the health department. There's a lot out there that should all be tied into the care that we're giving patients. Partnership Health Center is actually working on most of these things. I'll talk a little bit more about the super utilizer program that we have at Partnership in a little bit. And then appropriate care enables patients to access lower cost healthcare in a timely manner on their schedule. We may need to help patients with transportation, with flexible clinic scheduling, et cetera. This data piece, basically we need to know who our patients are, what their needs are, and what our resources are, and then start to build on those. This next slide is taken from the Oregon Primary Care Association, and this is an example, and it's looking more closely at patient data and starting to identify subpopulations, and then looking more closer at the issues that might be contributing to their poorly controlled diabetes and trying to address those underlying issues. So not just tracking the A1C and adjusting meds and dispensing lifestyle advice that's not followed. So what they did here is, so 10,000 people, 834 were diabetics, and a certain subset of that had an A1C greater than 9. And then, so who are those people? And what they found is, that of those, 2 seem to have some instability in their life, that they missed 2 appointments in the last 6 months, are living below the federal poverty line, may not natively speak English, mental health, or did not graduate from high school. So maybe we can start addressing what the barriers are specifically to those folks and addressing that. So, okay, so how do we get this data on who these folks are, what are they missing? This slide is super busy, and I apologize, but there's a tool out there called the Prepare tool, which is a protocol for responding to and addressing patients' assets, risks, and experience. And it's a national effort. It comes out of the work of the National Association of Community Health Centers. It's available for free online. And the idea behind it is to collect the data to show the complexity of the patients we care for, sort out what those needs are, and then also argue for payment changes. It's essentially used to find out more about our patients and then argue for funding to provide the services that'll truly improve their health. So it positions healthcare centers to document the extent to which each patient and their total patient populations are complex. And then we want to use that data to improve health, effect change, and sustain and create community partnerships and resources. And it basically asks patients a whole bunch of questions about their life and starts looking at your specific patient population and what their needs are. So lots and lots of measures. It gives us the opportunity to start cataloging what the current resources that we have in a community are, and then also what we don't have, what's missing. And the challenge in healthcare is that we feel like we don't have the power to address social determinants of health. The solution here, what we should be messaging to the powers that be that fund, is that we have to start somewhere and start collect this information and then build on that. So there's a lot of models to address social determinants of health or a patient's unmet basic needs, but it includes referrals with partnerships. And ideally, this is actually all happening in-house or with close communication, not just, hey, go down the street to Social Security. Navigating Social Security, navigating WIC, navigating all of those resources is not a simple thing, and it would be nice if you could do kind of direct warm handoffs, have community navigators that help you sort through how to do all of the paperwork, things like that. Expanding teams to include non-clinic members, so legal aides, housing advocates, and social workers. So the idea is start to catalog your resources, collect data to identify gaps, and then build collaborations and teams to address those gaps. So what are we doing at Partnership Health Center to start? We were actually unable to roll out the Prepare tool. It's supposed to be compatible with most of your electronic health records, and it is actually compatible. with ours, but it was too clunky. You were nursing, or whoever was doing the intake was going to have to double document on way too many factors. So it was really too complex to incorporate, which is unfortunate, but it just, it was going to take too long for nursing to even begin to start asking these questions and then trying to incorporate them into our system. So they've created a modified workflow that I'll kind of really briefly go over. But as you can see, even this is complicated. Essentially, once per year, we're now asking patients simple questions about their unmet basic needs, about housing, food, safety. And then if they respond that they do have those needs, we ask patients if they're interested in hearing more about options for support. And if they're interested, we try and do a warm handoff that day too. We call them our behavioral health care managers, but we probably should just use the term care management now because their role has evolved. But they can do direct handoffs to social work, to counseling, some referrals to our financial navigators. We are working to have a lawyer available periodically at clinic to allow patients to access their services for free, because we know that's a big challenge. People get embroiled in legal disputes, and that takes all their time and often a lot of their money, and that's sort of their biggest issue. I will say I have a patient right now who has a number of issues, but he has been just kind of diabetic, smoker, poor health overall. He has been really struggling with making kind of healthy lifestyle choices, cutting back on his smoking recently. He was doing really well, and then he kind of has fallen off. And ultimately, what it turned out is he got this letter from Social Security, somehow making him think that he had been overpaid and was going to have to pay that money back. And if he couldn't, he was going to go to jail. And he was just feeling completely overwhelmed by this. And he has been plugged into our super utilizer program. And Chaz, who you'll meet shortly, he went with this patient actually to the Social Security office and sat through a meeting with him, and they took care of it. And he feels so much better and is making better choices, and his blood sugar numbers look better. And so something as simple as that was truly really affecting this patient's ability to care for himself. He was just feeling so stressed out. So just a little bit more on our super utilizer program. So super utilizers, these are patients identified with complex comorbidities and significant social barriers to accessing primary health care. And they continue to seek care in the ED and through inpatient hospital stays. They comprise about 5% of Medicaid patients and account for almost 50% of program costs. So sort of this idea of hotspotting or identifying these patients who are utilizing a lot of resources, probably without much benefit in their health outcomes. So this was funded, jumping ahead. We were able to get funding through this through a grant through the Montana Healthcare Foundation to pilot a program. We have an RN and behavioral health care manager, and the team works to remove barriers to access. They do home visits, bring medications to patients, help coordinate care between settings. And these are some of their outcomes in the first 6 months. So they enrolled 29 patients. They've seen a decline in both ED visits and hospital stays, and at this point, just in those 6 months, estimated cost savings of $566,000 before program costs. And program costs are not going to be terribly high. The average cost of each hospitalization decreased from $30,000 to $10,000. ER visits were less likely to result in hospitalization, suggesting that their overall health is probably a little bit better. And there's actually, Montana Medicaid has prepared a proposal to fund this project going forward and try and roll it out elsewhere in the state. This is a little 3-minute video that was recently on KPAX talking about this. Hopefully it'll work. It did earlier. So I'll introduce you to Chaz work and Ted Veseth, who are...
Need orthopedic surgery? No need to travel far. I operate with the most advanced technology, high-definition cameras, and experienced team.
Apologies.
We perform the orthopedic surgery.
This is not an authorized
Marcus
advertisement.
State Memorial Hospital, orthopedic surgery close to home.
Yes, it's true.
Those who deal with chronic health conditions can often fall through the cracks of our healthcare system and end up living in poor health conditions and ultimately costing the system a lot of money without getting any results.
MTN's Augusta McDonald shows us a new alternative model of care that's proving to help patients get the assistance they need.
Partnership Health Center's Super Utilizer program serves a certain type of patient. They typically lack the skills and resources necessary to deal with their chronic health needs and often end up in the emergency room on a regular basis. Over the past year and a half, 2 case managers at Partnership have been tasked with spending time with these patients in their homes in order to figure out why their health outcomes are not improving and what they can do to make them better.
They're affectionately known as Chaz and Ted. And this is Susan. Due to a car wreck 2 years ago, she's mainly homebound now and in need of surgery.
How has your life changed since then?
Drastically. It ruined my life. I have no social life.
In spite of their patients' complicated conditions, Chaz and Ted say they're resilient.
Between now and when we get the surgery, we have to make sure that Susan is living the best life that she can right now. And that means that making sure that she has the necessary supplies to so that she can go out in public, so that she can
make her bingo nights.
Yeah.
Right?
Yeah. Tonight's bingo night.
Tonight's bingo night?
This level of engagement, it requires something from the patient. And when you've got a chronic condition, oftentimes you don't have more to give. And that's where ideally we get to step in and say, hey, how can we help you out? What have we been missing?
The program gets referrals through a couple different routes, and the patients have to fit an inclusion criteria. That umbrella covers patients who typically live with at least one of the big 5 conditions, as they call them: congestive heart failure, COPD, diabetes, asthma, and high blood pressure.
What I've seen a lot of is patients becoming fatigued for caring for themselves. It's like a self-care compassion fatigue, where they're just no longer really have the willpower to check their diabetes every day, or to make sure their blood pressure is staying down, or to make sure their self-intake is as low as it can. Do that every day for 30 years and you're going to get tired of it.
Every case is different. Their latest results are showing that by reducing emergency room visits, their efforts are saving money and also improving the patient's quality of life.
It's those sort of tangible successes where we're actually changing the day-to-day experience in patients' lives by getting the healthcare crises out of the way so they can sort of live life again.
They work with about 20 to 30 patients at a given time. Their grant money with the Montana Healthcare Foundation that's paying for Chaz and Ted to do this work lasts for about another year. After that, Dr. Stanger told me they hope that their positive outcomes can be used to convince payers like Medicaid that this upfront investment in coordinating patient care is worth it. Augusta McDonald, MTN News, Missoula.
There you go. Okay. So that was a perfect example of how this can really incorporate it into a local clinic. What's really nice about the super utilizer program is that, these are individuals, if you think about, high blood pressure, these are the individuals with the highest of blood pressure. You're going to get the most benefit out of treating these patients. When it comes to, monetary or the benefit of medications, they're going to get the most benefit. All right, so wrapping this up to where we were talking before, the easiest way to think about social determinants of health is where we live, learn, work, and play. So all these factors determine our health outcomes, and our health is determined outside of the clinic visit. It certainly does not address all the needs of an individual, but it's a start. We wanted to thank the 2 individuals that you saw in the video. So David Terry was not on that video, but he's also been working heavily with these kind of programs. Chaz was on the video, and then also Ted. Lori Francis is our executive director of Partnership, and so she came from Oregon, where she's doing a lot of the same work. Healthcare leaders everywhere that are pushing boundaries and trying to make this happen, and then our patients. We're inspired by our patients every day who are resilient and overcome these barriers despite everything. Last, this is a quote from Shalon Irving. So she was a 36-year-old mother that died 3 weeks after giving birth. Being an epidemiologist, this was actually her quoted Twitter account. She sees inequity wherever it exists. She calls it by its name, and she works to eliminate it. I felt like it was perfect for our presentation. First thing we need to do is identify what's going on, define it, and then try to improve. These are some of our references. You can take any questions.
Thank you. What's been the response from other payers for this work? Have you gotten any interest, say, from Anthem or, I don't know, Cigna?
This may be a...
I don't know. I think that this is on the forefront and coming. I don't think that bigger payer organizations are necessarily addressing this at this point. I think for obvious reasons, Medicaid and Medicare are going to be the most interested because those are the patients who are probably the biggest utilizers, are folks who through the safety net trickle down to Medicaid and Medicare. I'm hopeful that it's coming, but I don't know off the top of my head exactly how they're looking at it.
Just one more comment to follow up. I guess I've just recently moved here from across the country. I was in Virginia for 18 years, and we're all going to see that we have the way we get paid depends on our patients' outcomes and so forth. And I think one of the things that's hard or frustrating as a provider is that there's a lot of onus on the providers to do so, but not a lot of sort of interest from insurance, although more than there used to be, to actually help provide some resources. And so I think that is going to be a long-term challenge as we try to move forward and improve care. And I don't know how we advocate with the insurance, with the payers, that we need their partnership in this. But
I think the way we advocate is the way we vote. We need to vote for legislators who are going to advocate for these changes to come down from the federal or state government until policy changes and we start looking at this stuff more closely and addressing it and having policy that's really addressing health and in equity and equality in general. We're probably not going to see big changes, is my sense.
I would agree. When you look at the reimbursement system, a lot of the people that are starting these kind of programs are hospital systems, which you would think is not necessarily where they would be motivated by. I would think that insurance companies would be interested in this kind of work because this decreases their reimbursement that they have to pay. Their hospitalizations are, in the super utilizer down 566,000. That's huge. So insurance companies should be interested in this kind of work. Yeah. All right. Oh, one more.
Sorry for taking the inside seat, making it hard to get the microphone to me. I really applaud the work the partnership is doing in reaching out into the community. I also want to applaud Providence in their work. I'm Bernie O'Connor, In-Home Services Director, and this is Sue Pelleggi, our Resource Center Director. And we've been working with Providence for several years now. We obtained a demonstration project opportunity through CMS a few years ago. It was a 2-year project, and based on success, we were able to drag it out to 3.5 years. We worked with over 2,200 patients discharging from both community and St. Patrick Hospital, and our re-enrollment or readmission rate for the population we worked with was about 9.1%. The average readmit rate at the hospitals was about over 12%. I think a big I won't say it's a solution, but I think a big factor is partnering with community-based organizations that have been doing this for years. We run nutrition programs, the Resource Center, respite programs, homemaker programs, what have you. And I think bringing more people to the table and providing information on those outcomes is really key to getting the bigger payers to participate in addressing these issues. I mean, they're very evident. We've collected a lot of information. We're currently operating on a Montana Healthcare Foundation grant, a 2-year grant, and we've worked with almost 500 patients in over 14 months, and our current readmit rate for Providence is 8.75. But anecdotally, you know, we've worked with an individual who came down from Polson area she needed dialysis work, and she was couch surfing and worked in getting her housing and furniture and getting her stabilized and changed her life dramatically. And we can't depend upon the health professionals to do that work. It's just time consuming, and Sue can attest to the amount of time we invest in these individuals to get them stabilized, but then we've created a relationship, a long-term relationship with them in those other needs that continue. Transportation. We bought a radiator for an individual who couldn't get to a medical appointment, and that changed their world dramatically. $35 radiator, you know. We can't, but again, we can't expect a medical provider to be seeking out supports for those things. So thank you for your presentation and your work you do.
Absolutely. Good morning and thank you. Wonderful work, and I'm Mary Hutton from here at Providence, and some of this work is obviously the work that I hold near and dear, and the partnerships that we've actually created with community partners. I would just like to say the glass is half full. And here at Providence, and in our EPIC system, we are just now starting to really pilot and have started to ask a lot of these questions within our own medical record, and are going to be continuing on that journey. So you will see changes in the medical record in regards to social determinants of health. So that is coming. There's part of it that's already here, and we are already taking strides towards that. We are partnering with our Poverello Center. We've got a medical respite program that we are really very actively engaged in. And then we are now starting on a new Housing as Healthcare grant that is going to be coming into Missoula. We're just starting here in 2018, where we're going to do a much deeper dive into the housing needs for our most vulnerable populations here. So many of you in this room, I'm sure, will be participating in those stakeholder meetings that we will be having over this next year. And so that was really exciting. And I would just say that, you know, there are just some incredible partnerships that are happening already in this community. And part of the reason that we even secured the Housing as Healthcare grant in Montana is we were invited by the Montana Healthcare Foundation to do that because of all of these wonderful partnerships that are happening. So the glass is definitely half full.
That's great. Thank you.
It's after 8:30, so we will wrap up. Thank you, everybody, for coming. We're happy to take some questions at the front if you have any.